Great. Welcome back to Healthcare. We're still on H721, an act relating to expanding access to Medicaid and Dr. Dinosaur. And now we're going to be looking at sections 5, 6, and 13, which all of them have to do with Medicaid reimbursement rates. So we're going to start with Department of Vermont Health Access, who's joining us. Alicia's joining us on Zoom. So welcome. And if you want to introduce yourself and then just start your testimony. I don't know, did you send anything in or are you just talking?
Just talking today, no materials.
Okay, great.
Good morning, everyone. Thank you so much for the opportunity to join. For the record, my name is Alicia Cooper. I'm the Director of Managed Care Operations for the Department of Vermont Health Access. To begin, I wanted to share some of the points that I believe Acting Commissioner Strumolo also began with this morning when she provided testimony. The Medicaid rate proposals that are included in this bill are generally not in the governor's recommended budget and therefore would need additional appropriations if they were to move forward. We do expect that there would be significant fiscal impacts associated with this proposed language that would require prioritization. And we want to be good partners in helping with the analyses of any policy, technical, and fiscal implications that might accompany this bill. And so with that, I will share some initial thoughts on sections that you had outlined at the outset.
Great.
For sections 5 and 6, which include requirements for DVA to increase reimbursement rates to be at least 125% of Medicare rates for the same services in certain categories. I'll start by saying we're conceptually supportive of increases to provider rates, especially when they have the potential to positively impact access for Medicaid members. We also acknowledge the importance of evaluating Medicaid funding options across all AHS programs and departments. In order for us to better evaluate some of the potential implications of Section 5 in particular, DVA would appreciate additional information from the committee about the services that are envisioned in primary care, mental health, substance use disorder treatment, and long-term care services. These categories have the potential to interact with multiple of DVA's reimbursement methodologies. So for instance, you might see reimbursement for mental health services appearing in our professional RBRVS fee schedule, our hospital outpatient reimbursement methodology, our hospital inpatient reimbursement methodology, and potentially other parts of our reimbursement structure. So having some additional information about how you're thinking about each of those categories would help us in defining some of the analyses that we would plan to conduct. We also wanted to note that these service categories have the potential to cross AHS departments and budgets. So for instance, long-term care services is listed in Section 5. However, the majority of long-term care services in the Medicaid program are paid from Dale's budget and work with Dale's programming and are not something that DVA directly has influence over with its reimbursement methodologies. So that just might be an opportunity for us to understand a little bit better what you're considering within that definition. I would note that not all services in these categories will necessarily have a Medicare rate that can be used for a point of comparison. I think many will, and so using that 125% benchmark will be possible in analysis, but there will probably be some exceptions where we'll want to have some dialogue with you as we get further into the analysis process. And then finally, in order for DVA to provide more detailed analyses, we just appreciate the opportunity to work with your committee to understand how we would construct some of those parameters.
And what was the last statement? Work with your committee
on how we would construct some of the parameters for analysis.
Okay.
And then for Section 13, which is a requirement for the Agency of Human Services to conduct a study on what changes to specialty care service reimbursement would positively affect access to care for Medicaid and Dr. Dinosaur members. DVA won't comment on behalf of the entire agency, but we do imagine that our department would offer support to the agency in its analyses of potential impacts affecting access to care. And this is another area where some additional specificity could be helpful in defining specialty care services so that we have the potential to consider services and rates across the different departments in the agency, and so that whatever analysis results is ultimately aligned with your expectations.
Okay. All right,
That's it.
go ahead.
That's all I
Yeah.
had for.
So basically, Diva saying, yes, we can look at this, but need some more specificity from us as to how broad or narrow we would ask you to look at it. Okay. Alyssa and then Art.
So I'm thinking about this in, various areas that you would have difficulty calculating this. And I'm also thinking about the BAA and an ongoing discussion that we've been having. And I realize that this just pertains to like the RBRBS schedule. And I know that various rates are set in different ways. But I think the intent of this is to tie to Medicare significantly more than Medicare. And so I think what we've typically done is we've done things like 125% of Medicare. What if instead, and again, I'm particularly thinking about the RBRVS, is instead of tying it to the actual rate that Medicare pays, tying it to the conversion factor. So like the conversion factor will always be set higher.
So
And-
so I just want to make sure people understand what you're asking without, I don't know how to say, let's talk about this and not go real deep into.
I'm just thinking that maybe that's a simpler metric that gets around things like Medicare doesn't actually have a rate for something. So how do you say 125% of Medicare when Medicare doesn't have anything? And I think it also solves some of the other issues that we have around like the fiscal years changing, because Medicare's fiscal year changes January 1st, our state's fiscal year is July. And like if maybe there's more creative ways to set these rates so that our intent that they be reasonable rates higher than Medicare, that if there's easier ways to set them other than just throwing out like percentage.
Mm-hmm.
So we don't have this constant battle of up down every single year. I'm maybe I'm not.
No, so I don't know if do you have a comment on that?
I think we would definitely appreciate the ability to have that conversation with our reimbursement team to sort of kick around some ideas about what might be workable. But I agree that there are potentially some ways that we could be sort of creative with matching the intent with some of the processes that go into staying in alignment with Medicare rates.
So, I feel like whether or not 721 moves, having this broader conversation is important no matter what. So, having maybe we'll hear from the provider community next, and then we'll think of a path forward of how to get to that point. Daisy?
I wonder if, Alicia, you can speak to this, or it may have been a question that would have been better for Addie. I'm not sure, but I'm just wondering in all of this, how, we're gonna dig into more detail from our end when at the same time we're collaborating toward the AHEAD model and, potentially moving away from the 1115 as that expires. So can you, and maybe some of this is for Lori too, like how do we move away from the 1115 and move together towards something that is aligned with the efforts of the administration right now on the AHEAD model, which we're not this committee is not actively in the details of.
Right, right. So that's outside of, I mean, we have oversight of that and we'll hear more as it goes on. But the negotiations are between the administration and CMS. I don't know if Alicia can answer any of that. I don't believe that our 1115 waiver necessarily goes away because of the AHEAD model. So Medicaid is still kind of its separate thing, although if you remember, and I think we'll hear more in the budget, and Alicia, stop me where I'm going wrong here. We're actually now looking at the piece of Medicaid that is not, actually, I'm going to stop talking because I know you know the answer. So I'm talking about the new thing we're trying with Medicaid. You know what I'm talking about,
Yeah,
right?
so Alicia, I'll just ask my question a little more succinctly. Can you tell me what happens to when the 1115 expires and we hear back whether we're part of the AHEAD model or not? How will this bill impact our next steps?
So I'll start by saying, I imagine we'll continue to have an 1115 waiver that's governing the terms of the Medicaid program generally for Vermont. What will reach an endpoint is our all-payer model agreement with the Centers for Medicare and Medicaid Innovation. And then the AHEAD model would be the potential successor model for Vermont's participation. I think it's a good question to ask sort of how some of these bigger ideas would interact with the AHEAD model. And I don't know that I'll necessarily have really good answers for you for today. And that might be something that other colleagues of mine from DIVA and AHS could contribute responses to as well. But I think it's unlikely that if we're even just thinking really specifically about these reimbursement provisions, it's unlikely that we would move into the AHEAD model and entirely, do away with an underlying fee-for-service rate structure. I think we're going to need that as our architecture for the foreseeable future, even as we start to change the way that we're paying for services for more and more providers under an AHEAD model or any other model. It helps kind of ground our understanding of payments in our current reality as we think about moving it toward the future. And so I think there's still utility in making sure that we have rate methodologies and levels of reimbursement that we think make sense in a fee-for-service construct, even if we're starting to build alternative payment models more comprehensively around those.
So folks who have just been brought into a case rate format, that's not necessarily going to go away.
Right. I guess I would not sort of presume radical changes for providers that are sort of newer to different payment structures as we move into the AHEAD model. I think it's going to be kind of a gradual evolution from some of the payment models that we've been working on, and to Chair Houghton's point, some of the things that we're hoping that we'll be able to start piloting in this coming state fiscal year.
Thank you.
Much better than what I would have. Thank you. Art, I apologize. You had your hand up first.
Oh, that's fine. And my question probably, Lori, is more for you than Alicia. Alicia. I put a big question mark when I read this bill against this section because I'm trying to understand where the 125% comes from. So it looks like you're saying that Medicare reimburses better than Medicaid. Is that?
Depends.
Okay.
But yes.
Okay, so this would say that just by what it's doing. So Medicaid is now going to pay 125% of what Medicare pays for services.
Right. So the intent, again, I'm speaking as a sponsor of the bill.
Yeah, right.
So the intent when writing this language is that if we expand the number of people who have access to Medicaid in the state of Vermont, we already know that Medicaid reimbursement, although it's been increasing, thanks to a lot of the effort in this committee,
Yeah.
is still not at par with commercial at all, or in some places Medicare. And so for providers to be able to see more Medicaid patients, we need to also increase the reimbursement rates.
Yeah,
And-
I understand that.
And I would, and as I said before, I would say this is a really important conversation to have, even without 721 moving forward. That every year we're in here talking about how we do this, and it's always, connected to Medicare. I think one year it was connected to Medicare and the rates actually went down because Medicare decreased their rate. So, but for the intent of the bill is the providers are going to be responsible for taking on more Medicaid patients. We need to increase the Medicaid rate so that they are getting paid for the services they provide.
Yeah, okay.
And
It
I'm
just,
sure 125% is the right number
okay.
That's just-
You threw it in there to make it be.
to make it have a number.
Okay, so, all right, then I understand. I understand the intent
Yes.
is to get the reimbursement up to where it should be or close. So that providers will take on more Medicaid patients.
Exactly. And be paid for their work.
Yeah,
People help.
I wonder if we want to tie it to Medicare is my only.
Well, and I think that's what
That's what Alicia
you're
said,
saying.
that's right.
Yeah,
Yeah,
right.
all right.
Yeah,
Yeah.
good conversation.
Yeah.
Any other questions for Diva? I think this will get fleshed out more as we start hearing from the provider community, which we're gonna do next. So we'll be back to probably have another conversation with Diva and can figure out how to move forward.
Can I just make a further point on that? So don't forget, right now, because Medicaid rates and Medicare rates are so low, that it's the commercial payers that are paying these super high rates, because essentially everybody with commercial insurance is subsidizing.
You're right.
the other. So, it's not only if you raise Medicaid's rates, then potentially Blue Cross Blue Shield will not have to increase
Subsidized those.
and subsidize, and that will lower costs for
Everyone.
everyone.
Probably the biggest thing for somebody who knew nothing about healthcare that blew me away is this Medicaid reimbursement.
Right, that people are not getting.
It's just like, how does a doctor see Medicaid patient? Some don't happen.
Some don't. We see it in rural
Yeah, I'm
transportation.
sure some don't. I mean,
Yeah,
you can't do it.
Right. I mean, that's one of the reasons we have a shortage of dental
I'm
taking
sure,
Medicaid patients.
I'm
Yeah,
sure.
Yeah.
Just dollars and cents.
yeah, that's
You know,
exactly.
keep the
what it is.
doors open. Yeah, okay. Thank you.
Great. Thank you, Alicia. I always say your name wrong. I'm sorry. Thank you. And we'll be back. And we're going to hear from the provider community next. So Jessa, do you want to come up? Good morning.
Good morning. Thanks for having me. This is Jessa Barnard. I'm the Executive Director of the Vermont Medical Society. We represent physicians and PAs, and this is actually my first time testifying this session to you. We've had lots of our members here, but I have not been here, so I'm happy to be here. And just as a reminder, we represent individual clinicians rather than the institutions or locations where they work. They're at all different kinds of practice settings and primary care and specialty care. And I'm going to ask for a little bit of your indulgence. I'll be very quick, but I just want to mention on the other parts of the bill that you've already taken testimony on. Our board just had a chance to discuss the whole bill. So I did want to let you know that last week they did take a position in favor of Section 9 of the bill, expanding the MSP program. So I wanted to share that with you. And so that support, as well as our conversation around expansion of Medicaid, is based on a 2020 policy that our board of directors adopted, reaffirming older principles we have around health reform and a statement of need for universal coverage. So our organization and our members strongly support everyone having universal access to comprehensive, affordable, high-quality healthcare centered on an increased investment in primary care, reduced administrative burden, and public health interventions that address social determinants of health. So again, we support the MSP expansion. There is interest in exploring the expansion of the Medicaid program for more Vermonters. Part of that is based in what's right for patients, wanting all patients to have health insurance coverage. Also, potentially a move towards more administrative simplification if there are more people under one payer, and have folks with comprehensive coverage. We know Medicaid covers more services than many other insurance types, and lower out-of-pocket costs. And that's a big barrier, as you know, to patients seeking and obtaining healthcare. With that, our board did have a number of questions and concerns around the proposal to expand based on the payment reimbursement rates. So the conversation you just had set me up very well and made a number of the points that I was going to bring up, but I'll put a couple additional details on it. So, the questions include what coverage do these individuals already have? So are these folks who were completely uninsured, or are they coming from commercial insurance? So that makes a big difference in terms of, we will now get paid for somebody who had no insurance and no ability to pay us before, versus this was somebody we were getting commercial, qualified health plan rates for, and now they'd be getting Medicaid rates, which traditionally have been much lower than commercial rates. One question that we didn't see addressed in the bill is also would individuals have a choice to not select employer-based coverage and receive Medicaid? So as the program expanded to the 26 to 64-year-olds, it was unclear if this was a option only if folks did not have other insurance options, or a choice for anyone. And so what impact would that have? Sort of what numbers of people are we talking about? And how would that impact reimbursement rates, as well as federal dollars available to the state and costs to the state, and potential cost sharing assistance for the individuals? So one of our principles that continues in our statement of health reform is that medical payments and reimbursement for care must be sufficient to ensure access to necessary care, especially primary care, and must expand beyond current Medicare rates. So we very much appreciate that Section 5 first calls on an increase in primary care rates to 125% of Medicare rates. But one of our concerns is that if we're reading the details correctly, that would be effective as of January 1st, 2026, while some of the expansion categories for the young adults and the pregnant individuals would take effect January 1st, 2025. So there would be a year without change in rates potentially. And then also with further Section 13, calling for a study of reimbursement rates for specialty care services with a report back by 2025. We would presume that specialists would already be seeing an expanded population for that time while we wait to hear what a study would recommend and then implementing any changes. Our board does not believe at this point that primary care and specialty care should be separated, and urges a comprehensive analysis of reimbursement rates for both specialty care and primary care. And I want to note that I am primarily talking about the RBS or professional fee schedule, because as you've already heard, there are a number of Medicaid fee schedules, hospital inpatient, hospital outpatient, drugs, all the community provider types have different fee schedules. So I largely focus on that professional services fee schedule, which is for the individual, physicians, PAs, nurse practitioners, and some other provider types are paid under that fee schedule. We already know that access to specialty care in Vermont is already a problem. And I know you spent some time probably looking at this report, but just encourage you to skim back to the joint AHS, Green Mountain Care Board, and DFR report on wait times from 2022. That has a lot of I was just skimming back through it for this, and a lot of sad but helpful data about, there's an average of 100 and more wait times between a PCP referral and the actual specialist visit for chronically ill patients. That was before COVID. Dermatology, neurology, psychiatry, and endocrinology services have the longest wait time, depending on the analysis. And I know I'm often in here talking about primary care. We work with a lot of primary care members, but these are a lot of specialty services for chronically ill folks, diabetes, heart conditions, if you have a skin problem, that's not something you want to be waiting months and months and months for follow-up for. And some of those specialties in this analysis are already accepting Medicaid at lower rates. So if you look at who does and does not accept Medicaid, Vermont does really well nationally, I will say. We should be really proud of our state. But there are some specialties, including dermatology and psychiatry, that are already accepting Medicaid at a lower rate. So we just want to make sure that people have access. And so we support adequate reimbursement for both specialty and primary care. So what are our recommendations? We recommend that before coverage expansion takes place, the state should complete an analysis of what other state public options or Medicaid buy-in programs use to set rates. And I'll talk a little bit more about did a quick look at that, not an expert in it, what those rates are and what impact they've seen on provider participation and patient access to care. And then again, the point I made, excuse me, about what insurance patients would already be having or losing if they transition into this program. And we suggest looking at a number of options for a reimbursement rate. So the 125% as proposed in the bill, but also 145 and 160% of Medicare rates for primary care and specialty care. And then also a comparison and an assessment of the pros and cons of benchmarking based on average commercial rates versus the Medicare fee schedule. And I'll talk a little bit more about that. That's not unprecedented. A couple of years ago, Vermont did an analysis of a Dr. Dinosaur 2.0, so expanding Dr. Dinosaur, and they actually benchmarked to Medicare, average commercial, and a midpoint between the two. So why are those the recommendations we make? As pointed out, Medicaid is generally the lowest payer for most services, with the exception of the 110% of Medicare rates for primary care services. But that's a subset of providers and services. And so for most other providers, including all specialty care, that's they are reimbursed at about 85% of Medicare under the RBRDS fee schedule.
So say who's they again?
So primary care services, thanks to you last year, are now at that subset of primary care services that are on an approved list for DIVA and approved provider types. That's at 110% of Medicare, but all other primary care services and all specialty services, I think I had my number right. DIVA could make sure I'm correct on this, around 85% of Medicare.
Thank you.
And Medicare rates, whether you're at the 110 or the 85, are well below commercial. So I included some useful little graphics. I know I like graphics. That commercial insurance rates are on average 143% above Medicare rates for professional services, physician services. And you'll see much higher, significantly higher for hospital, inpatient, and outpatient services. So that range estimates that, so for primary care, it's around 117%. And 144% for specialist services. So again, there's some graphics to show you kind of how Medicare compares to commercial. So we really think that the 125, actually not too far off from the primary care rate, but well below kind of a replacement of commercial. If these folks are coming off of the QHPs, getting commercial rates, that would actually perhaps need to be closer to 145% on average, blending services based on that latest Kaiser analysis. And other states that have looked at public options, and I will, again, I want to caveat this with, this is what I could find in a bit of searching, but I'm sure others could be much more expert in this. Washington State, for example, set a cap of about 160% of Medicare rates with a floor of 135 for primary care. Colorado looks to have set it around 155% of Medicare. And Oregon did an analysis of it. They have these states all have different kind of models. Oregon actually uses private insurance carriers, benchmarked a blended rate of about 145% of Medicare. But I would argue we need more analysis before determining that Medicare is the correct benchmark to use. And again, we've talked in this committee, and Representative Black made the comment, Medicare for these professional services has actually been cutting their fee schedule year over year. So that's why we keep coming into you and saying, please don't just match us to Medicare, because that actually means we're getting a year over year cut. So could there be a different way to maybe say we wanted to pick 150% of Medicare, how does that compare to average commercial? So actually the precedent for that, and it's in your bill in section 6 for dental, because dental doesn't have Medicare rates, it's actually based on a percent of, I think the wording is the largest commercial carrier in the state. So I think there would be a way to do that analysis of setting it to kind of a blended commercial rate rather. And I say blended, meaning because different providers have different commercial, they've negotiated different types of commercial rates. So different types of providers have different contracts. There's kind of a community fee schedule. Then there are some that individual larger institutions may negotiate with commercial. So you'd have to kind of look at which commercial rate you're picking. So that is our suggestion, is to kind of look at both various Medicare rates and a commercial option. So thank you for our feedback. Happy to answer any questions. You can go into. Yeah.
Alyssa, Topper, and then.
So regarding the 125 versus like average, or I think the largest payer is 140 something. So I'm thinking about this in terms of this this expanded eligibility, who these people are, who these patients are. And I think that we're assuming that for all these people, you will be receiving 144% if they were on, say, a qualified health plan, and now all of a sudden you're receiving 125. But we're not taking into account, number one, the administrative costs to try to collect that 140%, the cost sharing that patients have that often goes unpaid, particularly at these lower income levels. So I'm not sure. And the beauty of Medicaid is at least you know what you're going to get, and you're always going to get it, and you're going to get it from the get-go. And you don't have all the administrative costs of trying to then collect from your patients. You don't have people with high deductibles who have absolutely no ability to pay the deductible because they're making 200% of the poverty level. Sorry. But you just can't. So I mean, I don't think it's an apples.
I don't disagree with any of that. I'm saying we don't know that, I don't know that without seeing that analysis, it's hard to pick what that right rate should. Like without knowing how many of these folks are uninsured, underinsured on a QHP. Yeah, maybe that rate doesn't need to be 145, maybe 100, some other number is adequate, but I can't tell you that analysis. And obviously it'll differ probably based on specific providers too. Some providers see more patients who fall in different coverage categories. So it will hit different providers a little differently. I am just suggesting I think we need to look at all of those pieces, where people would be coming from, and then how that impacts the rates.
And the other thing to your point regarding, getting away from, and I'm really interested in getting away from Medicare because every year I wait to see what Congress does in December. But the beauty of the RBRVS fee schedule with Medicare is that every single thing has a value, an assigned value. The work that goes into something, the malpractice that goes into something, the region that you're in, everything that you can possibly do has a value. And I'm not sure I've seen in the commercial fee schedules, I'm not sure what some of these things are tied to. And so I would be very hesitant to move away from Medicare because I'm not sure if the commercial rates are based on whoever they're negotiating with, right, and rewarding some more than others. I would rather tie it to something that at least is steady that has a value.
And I think one thing that would be worth looking at in that direction, and we've talked about this for the Medicaid fee schedule, is ensuring that it is because you made the point about the conversion factor. The conversion factor, I think there are complaints with a number of components of the Medicare formula and feeling like they're not updated as often as they should be. The biggest one is the impacts on the conversion, because there's a number of inputs, and then it's all those numbers are multiplied by a dollar value, the conversion factor. And when that conversion factor goes down because the Congress doesn't have as much money, that just means we pay you less regardless. I think you could peg it to one option could be Medicare with ensuring that the conversion factor at least accounts for medical inflation each year. A floor of adjusting for inflation. Because that's really what Medicare should be doing. That's the biggest complaint with Medicare, is that they're not doing that.
And that's sort of my thought process of, maintaining the RVUs.
Right.
Because the RVUs are updated every year in, various categories, but, they're relatively constant. They make tweaks throughout as things change, but maybe having a floor for the conversion factor and stop tying the conversion factor to Medicare, and tie the conversion factor to Vermont and say, here's our floor, and every single year we raise our conversion factor by this amount.
I think that's could be a sensible way to do it.
That's what I'm thinking.
Okay, great. Good conversation. You catch all of us up later. Topper.
It was a great conversation. I'm saying, what was my question? I think it's related somehow to what she just said, but I just want to have a simple. Am I correct in thinking that you people would like to see the 145% of the commercial rate rather than the 125% of Medicare, the Medicare rate?
What our recommendation is to look at what rate, an analysis of what comes to the closest replacement of what reimbursement practices would be receiving under whatever insurance these folks currently have, to the best of our ability to analyze that. So if they're coming from qualified health plans, what is that rate close to? And how could we approximate that as close as possible? We may not be able, obviously there's going to be unknowns and caveats, but the goal is that if we are saying we are expanding our coverage for folks, well, not really expanding, changing coverage, we want to keep providers as whole as possible. And to Representative Black's point, there may be some benefit, administrative simplification and benefits of doing that, but we don't want to kind of penalize providers, especially those who take more Medicaid patients, and say, okay, now another 10% of your patient population is going to be on Medicaid, but we're paying you less. We're paying you Medicaid rates, not the rates you would have been receiving had these patients stayed on a qualified health plan. Does that, so what rates would, because that's the part I can't tell you today. Are these patients coming from no insurance? So actually any coverage is better and Medicaid's better than nothing. Or are they getting commercial rates on the qualified health plan? So first we need to look at who are we talking about and what numbers of people, it's the numbers are really small. It's different than if they're big. If they're coming from uninsured, it's different from if they're coming from commercial. And then for the piece of, well, what rate gets us, not before we even make a decision, what is the impact on the state if we say, set it at this rate versus this rate versus this rate? Because obviously clearly the trade-off is going to be that's going to cost the state more money, the higher the rates. So it's a balance of how whole can we keep providers? What is the cost to the state? But that and not, we feel like that's the piece that should happen first, we think.
Thanks.
Thank you.
Art?
Yeah. I'm only laughing because trying to digest this and understand it is hard. And that kind of leads me to my question. If I have a plumbing problem in my house, I hire a plumber, he fixes it, he gives me the bill and I pay it. Why can't we tie what we do, and this is thinking way outside the box, it's one I could see in health. Why can't we just pay what it is? Why can't we have a doctor see somebody, if it's $272.82, we pay $272.82 and be done with it? It seems to me you could get rid of the administration of tons of stuff that we really don't need. Just pay what it is. Is there any value in that? And has anybody ever looked at that?
Will.
Boy, how long do you have for an answer to that question? Gotta go back. I know, where do I start? Where do I start? I mean,
You know what I'm saying?
Started in
though?
1940.
I do know what you're saying.
Because we're, number one, it sounds like we don't trust physicians, we don't trust providers. Because we're saying, well, you charge $200, but I'll give you 150 because that's what some indice shows somewhere. It seems to me, and it probably wouldn't work. I mean, if it was that simple, we might do it. But on the other hand, maybe we haven't looked at it from a standpoint of, can we just pay what it is? Can we just pay the bill?
This is not really what you're asking, but I will say that one thing our members do support is a national single payer healthcare system.
So that was my question.
Our members support a couple of years ago, but I will say, caveat, not a state-based. And the
Okay.
problem is because state can only touch, You hear, I know your committee hates it over and over. You can touch this much of the pie.
Yeah,
Our
right.
members
Wow,
want to
this
fix
is
this
true,
much
too.
of the
This is
pie.
true, too.
Because if it's
We're
only this much of
touching
the
a little bit
pie,
of the pie.
our previous analyses showed our state probably can't afford it. And B, for our members, it's the number of rules by which they're playing.
If it's blueberry, I'm all
So if it were, so that would be one way of saying this is, and that's kind of what Medicare says. This is what we're going to pay for this.
Yeah.
This take it or leave it. There's no negotiating. This is the Medicare fee schedule. So it would be, basically some kind of Medicare for all type model. Our members are actually on board with that
in. Love
direction.
it, yeah.
But then you have to fix Congress. So.
Yeah.
That is
Well, it'd be a myriad of problems and it's probably undoable, but it seems to me that the rigmarole we go through to pay a certain percentage of stuff, it seems to me you could do away with all that and just pay the bill, but I don't know.
Is a very good question.
Everyone was a millionaire.
And it's just layer upon layer.
And that's exactly the thing I see it, just from a,
Rather
layman's
than look at the whole system at a national level and say, let's start over.
yeah.
How are we gonna do this?
And part of it's
like
trust.
Bernie.
Bernie. And some of this, you could see a value in it.
Right.
Because
Yeah.
it just,
Absolutely. It's too.
we're creating this monstrosity that's just hard to fix.
Mhm.
after
You
a
are
while.
exactly right.
Anyway,
So we will keep that in the back of our minds.
So sorry.
Sorry.
So I'm a bit blown away because I thought it was gonna be either Brian or me that brought that up.
Yeah, everybody did get to that point once. Yeah.
Yeah, so my point was exactly, wouldn't it be great if we had one payer? And the cost and the pricing wasn't determined by capricious, profit-driven multiple organizations that are monopolized nationally that leaves us with little power and room to. Some people would lose their jobs, because we would be cutting out all of this unnecessary, which could be unnecessary, maneuvering and trying to patch and fix, and so.
I suggest everyone write to their congressional delegate. Did you have a question, Maria? That was-
No, that was it, and then again, I was just flabbergasted that it came from Art,
Yeah?
and not me. But
Good idea, no matter where it comes from.
Yeah. Well, it just makes sense, right? Why are we pay for a plumber, we pay for an electrician, why are we not just paying for our healthcare, right? Like,
yeah, I mean, and there's so many things to it. I mean, like you say, people would lose their jobs over it, I think.
The other thing is,
Might be
everybody can't
repositioned.
pay for that.
Well, yeah, it can't just go to a cash-based pay for the service.
Well, they
It's too
can't pay for, I
expensive.
get that.
Yeah.
And that's right.
right,
That's right.
but
And I'm
can,
not saying that the person would personally
Right.
pay, but the system pay.
right, let's get to a simplified system.
Right,
Then we figure out
That's
who
right.
needs help and who doesn't need help. We're
Right.
paying for that
Right,
simplified
right.
system where we providers are getting paid for the care they give, which is vital to keeping Vermonters healthy.
yeah. Well, it's vital to getting providers here,
Right, exactly, that too, right.
getting them here and keeping them here. I mean, how long can you get a percentage of what you put in? It
Right.
just makes no sense.
And, sorry, I'm gonna go here. And get a percentage of what the cost is and have to deal with a lot of paperwork. Which is what we're talking about in 766. Okay, Leslie.
Great.
Because we do have more witnesses, so I want to make sure that we are moving on.
And I appreciate your board position on the national level. That's really good information. But I just had a question. You mentioned other states and their caps. And do you have any idea, you probably don't, how they fund it? Is it taxes or are there alternatives that?
I think they are different. I would encourage you, so I footnoted I thought pretty useful report, this, oh boy, now what foundation was this? CHCF.org had a nice report comparing some of the models. This is a couple years out of date, so there may be changes, but each one looks a little different, I believe. So one was sort of, I think it is Oregon was sort of more of a, I believe, like a mandated carrier participation, but offering a public option. Where I think Washington, it may be more of a Medicaid buy-in. So they're each a little, they're different flavors. And so they set rates differently and pay it differently.
And each have different levels of success.
Yeah.
And-
And they're in different stages, I think, of implementation.
Yeah.
I'm sure there are other experts who could tell you much more about those programs, not me.
Anything else for Jessa? Great. Thank you.
Thank you.
Very much. And we're back to Mary Kate. Thanks for staying with us all morning.
Oh, absolutely. This has been, again, I wish I were actually down there with all of you in the same room, but it is what it is. And again, for the record, Mary Kate Molman, Director of Vermont Public Policy at Bi-State Primary Care Association. And I feel like my testimony, I could modify to just say ditto to what all of you just said for the last 5 minutes. I feel like I rest my case. So thank you. Yes, I think for this bill, H721, to begin with, we applaud any increased investments in primary care, mental health, substance use disorder treatment, and oral health. These are all areas of our healthcare that need that investment. I would note that the rate increase as currently described in the bill would not apply to FQHCs, which serve almost a third of Vermonters. Federal government requires states to pay FQHCs in a unique way that cover the comprehensive services they provide and the unique regulations to which they must adhere. Our recommendation that as the committee continues to consider this bill, that we include language that would incorporate increases to FQHC reimbursement. And I'm happy to get into some initial ideas on that, but I don't want to get into the weeds at this point unless anyone's willing to jump down the rabbit hole with me. But we'd also recommend further analysis around what the financial implications would be on providers. We can get a guess, but I think to the points you've heard from a number of witnesses this morning, we need to understand more about the population that we're serving and what is the what payments are coming to health centers under the current system, and how would that change under an expanded Medicaid program. And lastly, we would just request additional analysis on that. And then regarding the dental rate increases, we fully support that provision.
I'm sorry, what was the last provision you support?
The dental rate increase.
Okay, great, thank you.
So any questions, I'm happy to answer.
So I would say, I think we're gonna probably be asking for some language suggestions from a bunch of folks. So I would say if you have some language to address the reimbursement rates for QHCs, that would be great. Excuse me, I'm losing my voice. Alyssa has a question.
All FQHCs have sliding fee scales, don't they?
They do, they're required to provide those up to 200% FPL.
Okay, thank you.
Anyone else have questions for Mary Kate? Great, thank you very much, Mary Kate. Hope your child feels better soon. I forget who's up next. Jill.
I'm gonna try to share a couple of slides. A little tricky. Audio. And
Nice picture.
what did you see? Okay, wait a minute, and then let me go to, here we go. Oh, no?
It's in back of you.
Well, the picture's
She's
in
trying
back.
to
She's trying to get her.
share. Thought I shared it. Let's try again. Share screen. Start broadcast. Everything on your screen will show. It's warning me. And I closed a lot of things. You can see what I'm watching on TV.
It's kind of there. Hold on, it's not.
I could give you some help if you'd like.
Yeah, you were my first call.
Right.
This is not working.
They needed.
I didn't even know what was happening.
It's not getting me
Got the pro
online.
here, Jill. She's on the case.
Oh, looks like,
He knows what to do.
it just started, right? I think it's working now.
I do want to know what your TV recommendations are.
Oh, I have so many. I watched so many.
So, there we go.
Okay, okay, so, hello, good afternoon. Sorry to be, is it morning?
It's morning.
Okay. Thank you for having me. Okay. I'm ready to talk about payment policy. You guys are so ready.
It's trying to get your computer on.
Okay, I got the computer going. Hello, I'm Jill Olson. I am the executive director of the VNAs of Vermont. So we represent home health and hospice agencies, and I have seen you before this session. And actually, I'm going to be touching on some of the things we talked about in my BAA testimony. I'm focusing today on Section 5. Our association has not yet taken a position on the rest of the bill. We have a board meeting coming up next week. I also think we're going to be challenged by understanding the extent to which it has an impact on us. I will say that most of the care that home health agencies provide is to people on Medicare, but not exclusively. But the Section 5 on rates, I think, is something that's really important for us to talk about, as you've already been discussing this morning. And it's funny, usually when we can, as a healthcare association coalition, we testify together, but you're in payment policy, so it is very parochial to each of us. And so that's why you are in fact hearing from all of us one by one, because it's different depending on the provider and how we get paid. So the first thing I wanted to point out is that in Section 5, it describes reimbursing providers and lists the providers, and it says long-term care services, but it does not say home health and hospice. So that would be just my first comment, that I think that was intended. I'm hopeful that was intended. But there's a lot of confusion about what we do. So long-term care is a piece of what home health agencies do. We do, in fact, provide that service to people at home. But mostly what we do, it's skilled home health and hospice services, nursing, therapy in your home, and then holistic hospice services. That is actually really what a home health agency is. In Vermont, it's a little unusual actually to have home health agencies, Medicare certified, so involved in the long-term care system. The other thing I think is important to understand is that, so long-term care is incredibly important. For most long-term care, there is no Medicare equivalent. It's mostly paid for by Medicaid for people who don't have some kind of rare person who has long-term care insurance. So it is a Medicaid program. And so Choices for Care, all of it, it's all that state funding with a federal match. There's no Medicare fee schedule. So I do think for home health, there are ways where you could sort of create one. You could take a home health aid rate and kind of impute it to a personal care rate. You could make them ride together and make sense of what their relationship should be, but there's not a fee schedule. So just in terms of kind of what are we talking about? So I did want to talk a bit about, more specifically about what I would hope to see as you're talking about how to sort of think about rates against Medicare or whatever, how to think about home health. So I am actually going to go a little deeper than I usually do on how the home health payment model works. So you may remember earlier this session, you supported a proposal to bring skilled home health rates to 100% of, and I always say this, LUPA Medicare, not Medicare, LUPA. So I'm going to talk a little bit more about what that actually is, because I think this is the moment. I don't know. I think we're here. I don't know if it's morning or afternoon, but even so.
Not for me for a loop.
I think, well, certainly you're the payer advocate, so we're all turned around today. Okay.
Slides to clear.
I will, yes, I will. I created them about 15 minutes ago, so yeah. So this slide you've seen before. This is just a reminder. Right now, what I'm talking about is the healthcare slice of this. I'm not talking about hospice even, which right now is actually linked at 100% of Medicare by federal policy. So I'm talking about skilled home health. So our current payment model is known as the patient-driven group, actually it's groupings model, and it was effective on January 1 of 2020. So it's a relatively new model, and it started just as the pandemic was starting. So as you can imagine, some of the transition is sort of happening now because everybody was so focused on the pandemic. It has several components, but mainly is what, if you heard my members talk, they would say it's an episodic payment model. What that means is they get paid for 30 days of care, depending on what kind of care you need and what level of care you need.
There are 432 versions of what kind of care do you need. That's what a case mix group is. So there's two kinds of admission sources. There's two kinds of timing, whether it's your first 30 days or your second. There's 12 clinical subgroups. I put some examples there. There's your functional impairment, meaning sort of how well are you able to take care of the things you need to take care of for yourself at home, low, medium, or high. So, can you take yourself to the bathroom or not? That kind of impairment. And then comorbidity adjustment, meaning whether there are other such things that clinical issues that you have that maybe aren't what brought you to home health this time, but are still an issue for your health. So it's literally, you get 40 to 32 because it's 2 admission sources times 2 types of timing times 12 groups times 3 impairment levels times 3 comorbidity is 432. So those things all work together.
And who invented this?
This is Medicare. So these things all work together. So when you multiply them all out, there's 432 essentially combinations of these different things. And we get paid differently for different combinations. Okay. Let me just stop there because it's confusing. That's the episodic model. So however many visits we do in 30 days, we get paid the same amount depending on which of those boxes you fall into.
I'm more familiar with admission source being hospital. How are
There are community referrals too from physicians sometimes.
so usually from physician's office?
Yeah.
Provider offices?
Usually from primary care.
Okay.
Yeah, most referrals are from the hospital, but there are community referrals as well.
Thank you.
Jill, didn't you say that Medicare, there's no fee schedule for Medicare
For long-term care, which is not what I'm talking about right now. So there
Okay.
is a fee schedule for nurses and therapists in your home, which is what I'm talking about now. There isn't a fee schedule for personal care. You
Okay.
need help with bathing or dressing on a daily basis over a long period of time. You don't need a nurse, you need someone to assist you with those things.
Okay,
No
so-
schedule for that.
So length of time is the big cutoff.
It's
for
really for
Medicare.
It's two things. It's whether you have what's called a skilled need, so whether you need a nurse or a therapist, and then also home health is always intermittent. It's always sort of you've been to the hospital,
Oh,
now you need
okay,
care
okay.
after. So it's not forever. Whereas
So Medicare covers home health, but it doesn't cover long-term care.
Correct.
Gotcha.
Correct, exactly.
Okay, thank you.
Exactly.
Yep.
So this is our episodic model. So this is actually our base model. This is how we get paid for most people, is this way. Okay. But there's a visit threshold. So, and it's different depending on which of the 432 things you're talking about. But essentially it means for a particular one, if we only do 4, if the threshold is 5 and we only do 4 visits, we don't get the episodic payment. We get a per visit payment. It's not as good. That's LUPA. Low utilization, meaning not that many visits. Payment adjustment. An adjustment means down. So we get paid per visit instead of the 30-day payment for the whole episode. And the thresholds, it used to be 1 threshold. It was always 4. And now it's different depending on your case mix. Okay. So this is essentially truly a fee for service model, the LUPA, because it's really a per visit. Our national association estimates that if you were to take all of our payment and sort of try to figure out, like, if you got paid just on this LUPA fee schedule versus the whole model, they think it's probably about a 75% model. So what I'm saying is you get us to 100% like you did in the BAA, which I hope will pass, really only at 75-ish.
Because of LUPA.
Yeah, because you're using the fees. It's 100% of LUPA, not 100% of the full model. Okay. But there's not really I could not credibly say, I know exactly what the amount is. If we were going to adjust this, it would be 75%. That's an estimate that's based on national information, and it's not. I would not feel like I had satisfied Alicia if I tried to say that. There's some work to do to figure out how you would make a conversion. It has been done. So Medicare Advantage plans, some of them pay us on a fee for service basis, but they actually use a conversion. So they don't try to implement the whole model, the whole big model. but they do have a conversion factor. So it can be done, but nobody has sort of agreed on a standard. So, so this is something that I actually think needs work. I think it would be good to understand what our rate is against true Medicare, not just against LUPA.
Okay.
Yeah.
What is your last, well, let's say? Because I can't.
Oh, Vermont Medicaid pays only on the LUPA schedule. So Vermont Medicaid does not implement the episodic model. We just get paid per visit.
Okay.
Using the LUPA fee schedule.
The legal fee schedule.
Yeah, there's some other differences too. The Medicaid fee schedule covers some things that Medicare doesn't cover. They're a little more flexible. So there's other differences. So it's not like there's definitely no like whip it out key on this. You'd have to do some work to figure out what it would look like.
Okay, we're gonna have a couple questions. Leslie and then Lori.
I'm wondering how much,
Stop
this
sharing.
Medicare episodic model versus the LUPA model drives care. Because wouldn't you want the nurse to go the fifth time and get the whole payment rather than not? And how much does that interact with this?
Yeah, so there's a tremendous amount of sort of oversight and documentation to make sure we don't commit Medicare fraud.
So that would be fraud. Because the
Yeah.
point is that the person doesn't need the fifth visit.
Right, yeah. So there's the physician order. This is something I would really need to go deep with my members on. I do not fully understand sort of their day-to-day like operational work of how to do this. But yeah, in Medicare, this is sort of the tension with Medicare. They're always trying to figure out how are any provider, not just home health, any provider trying to maximize the payment under the model. And providers, of course, want to make sure they go right up to, they don't leave anything on the table that they're entitled to. But also there's a tremendous amount. I mean, they audit us, they pull charts. There is a lot of oversight of how we get paid for Medicare and a lot of review of our claims.
I'm with Art.
Lori.
This may be a question for Diva, but maybe you know as well, why does Medicaid only use the LUPA model?
I think it's a lot simpler. I think it would be, and the federal model has changed. It just changed in January of 2020, and it was a different complicated model before that. So I think it's just a matter of both the complexity and then whether the complexity is worth it given the size of our Medicaid only payments. I think it's very fair for them to say that model is too complicated. It's not worth it given the number of claims there are and the size of the program. And that's why I say it might make more sense to have an agreed upon sort of conversion factor instead of implementing the episodic model. That's a conversation in terms of like what we'd be asking for. I'd want to talk to Alicia about like what would be a reasonable
That makes sense.
thing to study and look at. Yeah. But I think it'd be very fair to say, let's stick with the fee for service structure, but figure out a way to convert it to Medicare.
Okay.
Yeah.
Any other questions for Jill?
And one more thing I wanted to add, if that's okay, just for your information, layered on top of our federal model is a value-based payment model, meaning essentially pay for performance. So there is also some of this payment model is at risk based on readmissions to the hospital and based on visits to the emergency department by people who are being cared for by home health. What's really challenging about that is that it's very hard to really do our job taking admissions so that hospitals can discharge, I'm pointing at Devin, so that hospitals can discharge home and take the hard patients, take the ones who they're a little like, will they make it? And be a 5-star agency and get the extra payment. We can't really be the best possible partner to hospitals and perform really, really well on that as CMS has it. They just don't give us enough credit for that effort. And then the other piece is whether or not someone goes to the emergency department, that depends on the strength of the primary care system. So if we call primary care and say, hey, this is happening, we think this person needs their medication adjusted or whatever else it is, and they don't have the resources to deal with it, they might say, you got to take them to the ED. So we're trying to prevent it doesn't count that we tried, it only counts, the outcome is the only thing that counts, not the effort. And so that's just, that's part of the tension in our system is that not everybody can always do that. So actually I have members experimenting with working with even with a team in an emergency department to actually be the person we call to say, hey, here's what's happening, and having it be the emergency department physician trying to figure out what needs to happen and then trying to avoid the ED visit that way. So that's happening up in Chittenden County. So that's pretty interesting. Yeah, it's pretty cool. Yeah, yeah. I think that's
So is that everything? All right, so, I'm gonna say to you as well, language would be great. I'm envisioning we're gonna have a conversation about how we wanna maybe work as a subcommittee at some point, so to go work through all this, but language would be great.
That's just why it's so hard. You have to just say no audio.
I did.
I'm sorry, I'm not.
Maybe I just said the wrong way. Sorry.
That's, all right,
It's okay.
thank you, Jill.
Thank you very much. I appreciate the time.
Yeah. Whenever you're ready.
I don't know if I would want to be in an escape room with you two.
Hey, committee, is there room for me to come back in there?
So hold on,
there
Brian,
room?
what?
Is there enough room for me and my intern to come back in there now?
Yes,
Okay, we'll be right. We're coming in. I just wanted to check. I didn't want to interrupt the last witness. Thank you.
yes, thank you.
It's really hard. And it's really good to hear it again.
And
again,
again, and again.
Yeah.
It is.
Yeah, and I'll get everything up here. Okay, that video.
Your facial expressions are great.
It's not talking to me about audio, so I'm worried it's gonna do the same thing again.
Oh, you're connecting now.
This is stuff sent in.
Yes.
Yeah, okay.
This is the stuff that I sent in. And here we go. Okay. That will do it. So thank you all, and thanks for that brief interlude. Devin Green, Vermont Association of Hospitals and Health Systems. We represent all of Vermont's hospitals, all of which are nonprofit. Thanks for having me in today on this bill. We do support greater access to care. And so as we testified on Section 9 for this piece, we do want people to be able to get their care and not have costs be a barrier. So we're interested at looking at this further. And so we wanted to weigh in on sections 5, 6, and 13. So for section 5, we do really support, we're not going to weigh in completely because long-term care is not us. And a lot of these things are not us. Primary care does include us. And so we would want to see how that would work. But overall, I want to say, I'm going to try to say it every time. Our biggest concerns right now are long-term care, EMS, and mental health. So we really do appreciate increasing the rates for those providers because we know that they're struggling. We're seeing that impact in our hospitals now. Last week, we had only 6 ICU beds, mainly because we had 142 people waiting for long-term care. This week has gotten better. We have 21 ICU beds, and we have, I think, 137 people waiting for long-term care, but it's still definitely a struggling system. So definitely support increases in those areas. We want to support those resources.
You have your main. Oh.
Yeah, that's okay.
Okay, you're good. Okay.
I think the one thing I wanted to add in the section 5 piece was consideration of rate increases for prenatal birthing services and postnatal care. So if you are expanding services for
pregnant individuals, one place that hospitals are struggling are in paying for births in Vermont. So we're the lowest birth rate in the nation. And so, and it's a lot of resources to manage a birthing unit. And because we don't have a lot of people who go to our birthing unit, and we actually have 2,021 out of about 5,300 births who are on Medicaid now, that's been a real challenge for funding those units. And that's one of the reasons I know we've talked before about independent birthing centers, and the concern that we've had is independent birthing centers would draw commercial payers who typically fund our units away from hospitals closing the unit, and then the birthing center wouldn't have a hospital unit to go to, and we would both fail. So if we can find a sustainable way to support birthing units, we'd be very supportive of that. And I think that'd be crucial for that expansion to pregnant individuals.
And that is a separate reimbursement line item, so we would have to list that separately in language. That's something we need to look at. Okay.
Yeah, I mean, I think right now it falls in the section 13 specialty care.
Okay.
So my concern is
It's not.
the specialty care piece is not, there's a report for the specialty care piece. There's no, rather than implementation.
Can I ask you to just really quickly repeat what you said about the transfer between, hypothetically, between a birth center site and back to a hospital?
Yeah, so it's something, one of the requirements for a birthing center is that they have admitting privileges because if something goes wrong and they need to go to the hospital, that needs to be there because they don't have inpatient capacity. And so our concern when it comes to independent birthing centers is if the hospital birthing unit has to close, that independent birthing center wouldn't have it to go to.
Got it. Listen.
Just thinking if we move to more of a global hospital payment model.
Right.
Wouldn't have to worry about closing down your birthing.
Yes, that's why we're interested in the global hospital budgets. We just definitely need to see more details there, but yes.
Okay.
So I don't want to get derailed, but people have been asking about this issue, so I just want to ask this.
So, okay, we're not talking about any birthing centers, we're talking about.
Sorry.
But what I'm hearing is so if we were able to find a way to better support the existing services of the hospitals, there would be a place in the system of care for independent birthing centers without the risk and the challenge. If we could figure out a way to properly support.
Right.
To move towards, okay, that's what I'm really.
That would take care of our concern.
Yeah.
There might be other concerns about overall utilization of care or something like that, but our main concern is it's costly to keep birthing centers open, and how can we support them to keep them open so that they're there for the community, and also if an independent birthing center wants to come in, they're in there for that birthing center as well.
All right.
Sorry for
Okay,
the.
hold on. Questions are back to 721 if we want to have a conversation about.
It's not, it's about, it is about 721.
Okay.
I sounds like erroneously that birthing centers and hospitals were one, there are areas in the hospital systems that for whatever reason around funding and payers are able to bring in more revenue, and then other areas not. And it sounds like erroneously thought that birthing centers were, because there's procedure codes, which are usually paid at higher rates. I thought that birthing centers were sources of more revenue for hospitals.
No, birthing centers are not sources of more revenue for hospitals. They are typically subsidized by those other services.
Okay. And it sounds like part of it is that a substantial number of people who utilize hospital birthing units are paid Medicaid.
Yes, because we do get a substantial number of people who are covered by Medicaid, and so we are reimbursed at the Medicaid rate. And as you can see, and I just want to point out, so like the birthing center, maybe they would be, because we're still under fee for service. If we had a lot of births happening, maybe in other states, birthing units, can subsidize other areas of the hospital, but not in Vermont because we just don't have enough.
Right. Okay.
And yet at the same time, we know that if we take away the birthing units, families will move away. So it's just it's a tricky dance.
So we are back to 721.
We're back to 721, but that does bring me to the Medicaid space and our hospital financial picture. When we look at this bill, I think the immediate concern that comes up is Medicaid typically doesn't cover the cost of care. 9 out of 14 hospitals have negative operating margins. Again, this is a graph from the Green Mountain Care Board's consultants report that was done in 2021 that sort of shows the cost shift and the dynamic between Medicaid and commercial and Medicare, and hospitals wouldn't want to have to shift things over to the commercial space. So that's an immediate thought. But then the next piece is another slide that you've seen often, which is our uncompensated care is going up. And so, potentially having someone covered by Medicaid who wouldn't normally pay anything because they're on a high deductible health plan that they can't afford could become a benefit to hospitals as opposed to getting nothing. So it's a complicated analysis that we haven't done yet.
So tentatively in support, but with a lot of questions that we need to get answered through this type of analysis.
Yeah, we would want answers, and we would certainly want answers on the specialist rate prior to implementation.
Okay, Alyssa, Mari, and Brian.
Can you remind me again, because I think you said this in your testimony in a week or a month or however long ago it was. The patient assistance programs right now, they're all standardized now across all hospitals. What FPL was that?
Yeah, it's a great question, and Mike Fisher left, and they're not quite standardized yet. They're going to be implemented July 1st. I think, let me go back and look. I want to say 200% federal poverty level for fully funding, and then I have to go back and look. Let me look at that.
So theoretically, this expansion actually could sort of eliminate.
Potentially. Again, we want to dive into the numbers.
Thank you. That's it.
Mari.
Just a quick reminder of the difference between bad debt and free care.
Yes, so free care are the people who qualify for our financial assistance programs. That's considered free care. And then bad debt is considered people who don't qualify for our financial assistance program and we're unable to collect from them. And it sounds bad, but it's really like an accounting.
Brian.
So just to explore the numbers a little more here and understand it. Like I remember, so I don't know if you explained today what the dish payment is. I know what it is, but maybe before I ask my question, I should give you a chance as a witness to explain it, and then I'll ask my question. All right. So just
So the dish payment is a subsidy from the federal government and from the state. It's part of Medicaid to hospitals to make up for uncompensated care. So when hospitals are doing this uncompensated care, the dish payment is there to make up for it. Under the Affordable Care Act, there were cuts to the dish payment that were passed, federal cuts. We actually never hit our max for the dish payment. There's a lot more we could be getting. We're not close to it. It's at least 38 million and we're now down to like 24.
Because it requires a state match.
Because it requires a state match. But the assumption back when those cuts were made were that, the uncompensated care is going to be going down and down and down because so many more people are covered. And that's just not what we're seeing.
And this leads to my question. So I'm looking at here and so pointing out to the committee that as the dish payments have been cut, what is it looks like debt and free care is going up. It's not going up because dish was cut. It's going up because the need is higher, right?
Correct.
And so you're losing more money because the dish is cut, combined with the
Yes.
fact that the need is up, why is the bad debt and free care going up?
It's a great question. We think it could be a number of reasons, one of which would be high deductible health plans and people unable, we have heard that there are a high percentage of Vermonters who are underinsured and who are unable to do their cost sharing. I think that also goes to the Medicare discussion that we were having too. Medicare is there's 20% cost sharing under Medicare, and it's possible Vermonters can't make that. It could be a whole host of things. The answer is we're not completely sure, but we have our suspicions.
And then this you may not be able to answer, but a question that comes to mind is, this is documentation of the people who either out of necessity or mistakes or whatever have accepted healthcare and incurred a bad debt or received free care. Is there any tracking of how many people decline healthcare because because they don't want to end up with bad debt, or because they don't know if they're going to get free care? Like, is there any way, or do they just kind of fall through the cracks? Like when there's a recommendation, if they just say, no, thanks, I'm going to tough it out, I'll go home and see what happens, that kind of thing. Is there any documentation of how many people are not even getting care?
I would have to go back and look on that. I will say, and Mike Fisher has worked a lot with us on this. We are trying to standardize. I mean, our hospitals are all nonprofits, so we've always had financial assistance policies. And in the past, those have not been standardized. With the Healthcare Advocates Bill that's being implemented this July, that will be standardized, like creates a floor. And I know the Healthcare Advocate is working with hospitals in terms of promoting the availability of financial assistance policies and trying to ensure that folks do not walk out of the door without receiving care.
And that means free care could continue to go up.
Mm-hmm.
Yes, for the hospitals.
Or bad debt.
Or bad debt.
Yeah.
And so,
Yeah.
so the effort is a good one and a valid one, and what we should be doing, people should know that care is available to them. But it also will be a burden on hospital financials. Are you done?
For now. I do appreciate you answering the questions. I think it's helpful to better understand the story behind the graph.
Great questions.
Yeah.
Leslie?
Yeah, I'm curious to know about the dish payments and how that gets determined. What's that process?
That is it's a great question. And I don't know it off the top of my head. It's something I have to go back and look at. It's basically like a calculation that takes into account the amount of Medicaid patients at the hospital, and it sort of figures out a ratio and then disperses it that way.
Who's they?
The state determines
What state?
the Vermont.
Diva?
Yeah, state of
No,
Vermont.
Diva.
Diva, yeah.
Okay, so that comes from Diva. That's what I was curious about. Okay, thank you.
Sorry.
And sorry. Is each hospital then different? And is there a payment I knew we got an extra payment last year when the hospitals were really struggling during COVID, and that was really helpful. So is that something that happens once a year? How does that work?
I have to go back and see. I don't know how many times a year they get the payment or what the schedule is on it. So I can go back and get you more information on the nitty gritty details of the payment.
And I think one of the key factors is what Devin showed on the chart. We're not pulling down everything we could pull down from the federal government because the state is choosing not to provide the full state match. So if we could, and these are made up numbers, if we could draw down 20 million more, it would be 5 million that we need from the state to get that 20 million. That would help hospitals, but we're not doing that. It's just a policy decision. So this is a whole, again,
This is another can of
it's a
worms.
whole other conversation that
Yeah.
we can have at some point.
Yeah.
It's been a couple years since we've looked at it. But I think for this purpose, the point is expansion of Medicaid could help hospitals with that uncompensated care fees. But at the same time, if we don't increase Medicaid rates, then there could be a draw from the commercial side where the rates are higher to Medicaid, and hospitals could lose. So I think there's a common theme that we've heard from all the providers on that. Maureen?
So to tag on to that and Brian's question about bad debt and free care, how that's going up, this is rhetorical question or just a comment that I would bet part of the reason it's going up is because people don't have access in a timely fashion to care when they need it, like an endocrinologist for diabetes, and so they get complications admitted to the hospital for care or whatever. So I bet that's in the mix too, at whatever percent.
Okay, I know we had someone else in the room who wanted to testify, but it is lunchtime, so I'm gonna say we'll have you back. And appreciate Devin. I'm just gonna say if you have less language suggestions.
Yes, I just thought of the birthing thing, like talking to people 20 minutes ago, so I will send you language on that.
Yeah, and we have a couple more sections to go through, and we're gonna come back and have some committee discussion about what we do with all these language suggestions, how we're gonna work it all in, and we'll go from there. But it's been a good, long morning, really interesting conversation. I really appreciate everyone's engagement and the questions. And we are actually gonna have extra time. We are not back here until 2. At 2 o'clock, I've asked Diva to come back in. So if you remember when Sandy Hoffman was here, she talked about how we're switching to prior auth, 766. She talked about how Diva eliminated all prior authorizations. I asked her to come back so we can dive into that more to fully understand what their analysis was, why they did it, and what they're seeing as we figure out what we might do in 766. So that's at 2. It's only 45 minutes, so please be here on time.
We're not meeting at 1:15.
We're not meeting at 1:15, so I'm